During this session, we're going to cover the following topics: fee schedule definitions and the background for establishing fees for procedures and services, compliance around claims payments, and payer contracting. In preparation for this presentation, I did consult with a number of individuals to give you a well-rounded perspective on these topics. These individuals included other division administrators, Department of Medicine Administration and Finance, private practice administrators, a colleague of mine who is the Senior Vice President of Operations at a private practice hospital, and MGMA, the Medical Group Management Association. The fee schedule of an organization, private practice, or academic center was not an arbitrary guess for billing amounts to patients and insurance companies. There's a philosophy behind it. The fee associated with each billing code, or CPT code, was established based on the amount of work and practice expense the service required relative to a Level 3 established patient office visit, basically a 99213. Let's review the background of this process. CPT codes. Every single procedure performed has a CPT code assigned. CPT is a nationally recognized numeric and alphanumeric system used for defining what providers do for patients. Every CPT code has two components, a professional component and a technical component. The professional component is the value of the physician or advanced practice provider's time to perform the service, and the other component, the technical component, is the value or expense to the practice for owning the equipment, paying malpractice insurance, leasing space, employing staff, purchasing supplies, etc. The fee for each CPT was vetted through the RUC process. The RUC, or Relative Value Update Committee, in 1992 established the usual and customary based fee schedule for each CPT code. The recommendations were provided to CMS or CMMS, otherwise known as the Centers for Medicare and Medicaid Services. RUC is also charged with review of new procedures and CPT codes to recommend their value to CMS. This process often takes years and is finalized after extensive clinical review. During the review process, providers, through their associated medical societies, provide input on the work value of the service. WRVUs, or Work Relative Value Units, are one component of the value of a CPT code. For physicians, the value is assigned to every CPT code for the effort in performing that service to patients. Used as a productivity measure and as a payment mechanism for payers, Work RVUs can change, but not very often, and only after extensive RUC review. The fee schedule is set using a Work RVU multiplied by a conversion factor of the payer, contract, or the practice. This sets the fee or the reimbursement. There is also a Geographic Practice Cost Indice, or GPCI, adjustment for each location across the country. This is applied to the RVU of the CPT code if needed. Documentation. With the use of EMR systems, templates have become easy to use in documenting visits. From a billing and compliance perspective, documentation is key to supporting the service provided. If it's not documented, the service never happened. Remember, that's also the way you document what's done for the patient and could be a way to communicate to the referring physician. When you join a new practice, academic or non-academic center, meet with the coding and billing people regularly and get feedback on how you are doing. Ask if there are keywords or phrases that will document the work that you do or that you have done and improve coding. Get your productivity data to help understand how you measure against your peers. This will help you to ensure that you are on track with your contract if there's a productivity component to your compensation. Also, you will want to make sure that you are staying on top of any compliance concerns with coding and documentation. Again, the coding staff can provide you with these details. Review your fee schedule and know what patients are being charged. Some patients will ask you about the bills that they might receive, so it's a good idea to be ready and prepared for those questions. In the next section, we will look at an example of how services are billed. In this example, we're going to look at a Level 4 new patient office consult using CPT code 99244. I should mention that Medicare does not recognize these consult codes. However, there is a crosswalk to the Level 4 new patient visit of 99204 that is recognized by Medicare. This level of service requires a comprehensive history, comprehensive exam, and medical decision-making of moderate complexity. Typically, this level of service requires an hour worth of face-to-face time with the patient and/or family. Incidentally, you can code a new patient visit every 3 years. The patient is considered to be new to the practice if there is a 3-year gap in service. Also, there are some specialties that, while in the same practice, are considered separate. For example, electrophysiology fits this criteria. It is recognized as a separate specialty from cardiology, even though it is technically part of cardiology. So the cardiologist can bill a new patient visit, and then the electrophysiologist, seeing the same patient the next week, can also bill for a new patient visit. Back to our example. In this example, the fee schedule is set by the physician's organization, and it's listed as $488. The organization would have used its own methodology for arriving at that fee. The insurance payer, in this case Medicare, set their reimbursement using the RVU multiplied by a conversion factor and then adjusted to the geographic area. 99244 has a relative value unit of 3.02. And in our Medicare market, the conversion factor is $35.75. So the payment is $107.97. Depending on the payer, part of the payment may come from the patient, like a copay, $5 or $10, or a percent of coinsurance. But the total allowed reimbursement is still $107.97. If the organization is a hospital, the conversion factor for this service is higher at $56.62. Back to our example, in our market, we also have payer contracts that pay us to care for a population of patients. These managed care contracts pay us an amount per member per month for all of the care that the patient receives. Simply stated, the more care provided, the less we actually make. So in this example, the average collection for all sources, including managed care, is $124. The point here, regardless of what the numbers are demonstrating, is that we start off with $488 billed and only collect an average of $124 from all sources, including patients. This is basically a collection percentage of 25.4%. Then from there, we have to deduct another $80 for overhead expenses. For instance, support staff salaries and benefits, physical space, information and technology, insurance, etc. This is about 65%, an overhead percentage of about 65%. This leaves us with $44 for physician time and to feed into the compensation plan calculation. Earlier I mentioned the RUC process for establishing values of CPT codes for procedures and services. After payment is made, an organization might encounter a RAC audit. RAC, or Recovery Audit Contractors, get paid when they discover errors and fraud. The auditors receive a percentage of the recouped fees, and the penalties assessed are severe. In one case, a physician billed consults but did not document them correctly as consults. The fines levied were $435,000 plus the take-back of all of the incorrectly paid claims, and the physician was not allowed to rebill for them. And finally, he was banned from participating in Medicare for life. It was recently announced that non-government payers like Group Health, Blue Cross Blue Shield, etc., are utilizing the same methodology to audit and recoup payments. The reaction to a potential RAC audit is to undercode the visit. It's very common to do that. However, I caution you not to undercode your levels of service for office visit or hospital visits, because undercoding is also a compliance violation, and the same types of fines could be levied. The point is to adequately document what you do, and your documentation should support what you bill. That's all. Document what you do. Finally, to summarize a few things, some colleagues of mine provided me with some information for you to consider. Again, as I said, familiarize yourself with the fee schedule. Document what you do and then bill appropriately. Meet regularly with coding and compliance staff, And remember that coders and billers are your friends. They are not the enemy. They may ask for amendments to your notes or ask you to change your wording slightly, but they are there to help you. Thank you very much for your time. Please feel free to send me any questions that you might have or plan to attend one of the Q&A sessions that will be scheduled. Best wishes for your future in whatever path you choose.